Dear audience and committee, good morning, and thank you for the honor to participate in this session. My name is Eleni Konstantatou, and I'm a radiologist in private practice. For the next 20 minutes, we will briefly talk about benign and malignant bone lesions in CT and MRI. We'll talk about the common benign and malignant lesions and diagnostic methods used for imaging and characterization. Bone lesions are categorized into benign and the malignant lesions are subcategorized into primary and metastatic. So, what are we looking for when we are trying to characterize a bone lesion? First, we decide about the tumor's margins and matrix, whether it is a lytic with well or ill-defined borders or a sclerotic lesion, and then we'll build a differential diagnosis based on the patient age, tumor location, and any other ancillary finding like cortical destruction and periosteal reaction. And when we're talking about periosteal reaction, it's actually a non-specific finding for calling a lesion benign or malignant, because the only periosteal reaction type that equals benignity is the solid type. And this is a case of a benign osteoid osteoma causing a benign looking solid periosteal reaction. And while we know that malignant lesions cannot cause benign periosteal reaction, benign lesions can cause aggressive and malignant-like periosteal reactions. In cases of infection and eosinophilic granulomas, where we can actually see some cortical destruction. This is a case of frontal sinusitis with cortical destruction mimicking an aggressive malignant lesion. So this is a very well-designed table, mainly giving us the differential diagnosis of bone lesions based on age and bone lesion characteristics. We know that most bone tumors are osteolytic, but the most reliable indicator in determining whether these lesions are benign or malignant is the zone of transition between the lesion and the adjacent normal bone. Once we have decided whether a bone lesion is sclerotic or osteolytic, and whether it has a well-defined or ill-defined margins, then the next question should be, how old is the patient? Because age is the most important clinical clue. And that's why, as we can see from this table, is because patients older than 40 years old have metastasis in their differential diagnosis, irrelevant of the tumor margins or tumor characteristics. And the second thing that we can find from this table is that infection is in the differential diagnosis, irrespective of age and tumor characteristics. So, how can we depict these lesions? There is no single method used that can give the answer, and in real everyday life, a combination of methods is necessary for best patient management. A combination of X-rays, CT and MRIs, a PET CT scan, SPECT, or a bone scintigraphy scan. What's the role of X-ray? X-ray, in addition to patient history, is very important to have so that we can determine tumor location, tumor matrix, but we cannot actually differentiate between lesions containing fluid or a solid component. But X-ray is the starting point, and CT and MR images should only be interpreted with concurrent radiographic correlation. CT scans are superior to MRI for the assessment of mineralized structures. It's superior to assess cortical integrity and superior when it comes for assessing matrix mineralization and periosteal reactions. Some small lucencies of the cortex, localized involvement of the soft tissues, and thin peripheral periosteal reaction can actually be best seen when we have a CT scan. What we need to keep in mind is, as we saw earlier, a narrow zone of transition, meaning a well-defined border, equals benignity only in young patients, younger than 30 years old. For patients older than 40 years old, metastases are always in the differential diagnosis. The role of MRI is actually superior for soft tissue evaluation, to identify skip lesions, to differentiate osteoporotic from metastatic compression fractures in spine. And when it comes to multiple myeloma, we use whole body MRI scans to demonstrate the tumor burden. What But what's the major advantage of MRI is that it can actually depict and demonstrate the deposit in the bone in advance of any cortical destruction and before any pathologic osteoblastic process manifests as a hotspot in a bone scan. It's not always easy to differentiate benign from malignant bone lesions, and that's why many reports end with the sentence, non-specific bone lesion. Further imaging workup is required. So what's the optimal imaging? We know that MRI has higher sensitivity and specificity for tumor depiction than CT. And although PET scan has better sensitivity, has really low specificity with many false positive scans, best sensitivity and specificity is achieved with bone lesion specific PET scan with fluorine 18 labeled sodium fluoride. So some features that favor benignity is fat within the lesion, like in this case of a calcaneal lipoma. The well-defined borders for patients that are younger than 30 years old. And there are some features that favor malignancy, like the existence of soft tissue component, of course with some exceptions. When we have a new lesion in a patient with a known history of malignancy, again, we need to keep in mind that radiotherapy changes can actually mimic malignant lesions. When some soft tissue is located in both sides of the cortex, with the cortex remaining intact, then this means a very aggressive lesions that actually has gone through the cortex channels. When we have perpendicular periosteal reaction, and in patients above 40 years old. The most specific features of malignant lesions are the cases where the soft tissue exists in both sides of the cortex with the cortex preserving its integrity, and the perpendicular periosteal reaction. Some general principles that we can have in mind when we are reporting or when we need to assess a scan in MRI that favor benignity are when the lesion signal intensity in T1 weighted images is higher than muscles and the intervertebral disc, in contrast to this MRI scan where the vertebral body has a lower signal intensity than the intervertebral disc. When there is loss of signal intensity in chemical shift acquisitions, again, in contrast to this scan where the bone marrow does not show any loss of signal in chemical shift, when we have extensive bone edema. And we need to remember that enhancement is not actually helpful because both benign and malignant lesions enhance. CT favors benignity when there is absence of bone destruction or malignant periostitis, and when we have some typical imaging characteristics of the do not touch lesions, which we cannot actually talk about in this lecture. But, and there is always a but, when we have an infiltration of less than 20%, we cannot actually distinguish the deposit from normal marrow with standard MR pulse sequences, and the scan may be just normal. And some authors have actually reported that a normal bone marrow MR signal is actually seen in some hematological malignancies. We'll see some common benign bone lesions now, like osteoid osteoma, which represents the 13% of all benign bone tumors. It's in the differential diagnosis when a sequestrum is seen. It's cortically based in 80% of cases. Calcification of the nidus is possible, and the nidus shows a high signal intensity on T2 weighted images and has a strong contrast enhancement. Osteoid osteoma is really hot in bone scans, and this sometimes can be a problem. But when we have known that the CT scan has that pathognomonic imaging features, with the calcified nidus and the very nice benign solid periostitis, then we have no consideration to call that lesion benign osteoma. That is a case of a young patient with knee pain that an MR was performed, and we actually, what we saw at first was that extensive bone marrow edema and some soft tissue swelling. We couldn't actually identify at that point something going wrong, but then a complementary CT scan was performed, and we actually saw a very nice lytic lesion in the cortex with a nice calcified nidus, which actually, in retrospect, was that very nice iso-intense cortical lesion. Another benign bone lesion that we should actually be able to differentiate from possible osteoblastic met is the bone island. Bone islands are typically smaller than 1 centimeter with possible slow increase in size over time. And we need to know that a sclerotic lesion can be diagnosed as a bone met versus a bone island when the mean attenuation is below 800 Hansfield units and the max attenuation below 1,000 Hansfield units with great sensitivity and specificity. Nuclear medicine, there's usually no uptake, so a normal bone scan can exclude the met, even though some low-grade activity has been reported in histologically proven anastosis. That's a very typical bone island in the femoral head with a mean attenuation value of 1,200 Hansfield units. Another bone island in the spine. On a CT and on T2 weighted images, there is a really low T2 signal intensity. An osteoma is a benign, slow-growing, usually asymptomatic bone lesion that may be incidentally identified as a mass in the skull, sinuses, or mandible. We can actually see uptake in bone scan, and that may be a problem at some times. This is a very typical location and location for an osteoma with very typical morphological findings. That is an actual case from an oncological patient that bone scan was performed and there was a hot spot in the skull. Bone met was actually considered and immunotherapy was about to be seized. But we performed a CT scan and that very highly pathognomonic lesion was found, that an osteoma in the left frontal sinus, which was actually stable when we retrospectively saw some scans from 2 years before. So that was an innocent osteoma and the patient continued the immunotherapy. A very, very common bone lesion that we encounter every other scan that we report is a hemangioma, which when has typical features, is really easy to report. It has a bright signal intensity in both T1 and T2 weighted images, and that's because it contains fat. And it has also really pathognomonic and typical imaging features in CT scan because it really preserves the trabecula of the bone. Exostosis is a synonym for osteochondroma. You can diagnose an exostosis when you can actually identify the continuation of bone marrow and trabecular bone structures into the exostosis, as well as the cartilage cap when it comes to an MRI. The malignant degeneration occurs mainly in tumors near the trunk. So this is a typical exostosis with continuation of the bone trabecula into the exostosis, and this is the expected cartilaginous cap in MRI T2 weighted sequence. you can just expect to have a malignant degeneration when what you thought it was an exostosis demonstrates pain, tracer uptake in bone scan, growth, or cortical bone penetration, and that's a really badly gone osteochondroma to chondrosarcoma on an MRI scan on the left and on a CT scan on the right. Non-ossifying fibroma is a very famous do not touch lesion. We never biopsy, or we never touch that lesion because it actually disappears when it heals and becomes sclerotic. We find this lesion in patients younger than 20 years old. It should demonstrate no pain, no periosteal reaction, and most of the times is found in the metaphysis of long bone in a centric position. We expect to find a lytic lesion with expansive growth and scallop, well-defined sclerotic border, but MR imaging shows variable signal intensity and variable contrast enhancement. What we need to know and remember is that during that healing period, where the non-ossifying fibroma tends to be sclerotic and actually disappear, is hot on bone scans indicating the osteoblast activity, and we should never confuse that or misinterpret it for a malignant lesion. This is a non-ossifying fibroma with a non-specific features on MR imaging on that T2 facade image, and has quite clear and quite typical imaging features on that CT scan with nice sclerotic borders, a centric location in the metaphysis of that femoral bone. Achondromas have variable appearance, have a narrow zone of transition, sharply defined margins, chondroid calcification, and more commonly are found in hands and feet. They should have no gross bone destruction, no periosteal reaction, or no soft tissue mass. What we need to remember again is that differentiation of an enchondroma from low-grade chondrosarcoma is problematic, as they can have similar appearances and we cannot actually tell from the radiological point of view. On the right, we can see a pathognomonic case of an enchondroma with the tumor calcification, the cartilaginous calcification, and on the left, an expected bright T2 facade single intensity image of an enchondroma of the metaphysis of the tibia. We'll talk about some common malignant bone lesions now, mostly about the metastasis and multiple myeloma. And I've chosen to show you some cases of vertebral fractures because these are common and everyday problems in clinical and radiological practice. We see some weird looking vertebral bodies and we don't actually know whether the vertebral fracture is benign or malignant. As we said earlier, what we need to look for is whether it comes to CT scan, it's quite funny looking, quite ugly, quite homogeneous, mixed lytic and sclerotic lesion with some soft tissue component of prevertebral soft tissues. On MR image, there is loss of the, there's no loss of the signal intensity in the out of phase chemical shift imaging, and in T1 images, the signal in the image within the pathological body is lower than the adjacent intervertebral disc, and it's quite lower than the adjacent muscles. So these are highly suggestive of that being a pathological fracture. That was a case of, in the long term, that was proven to be multiple metastases, bone metastases from an unknown primary, we never go to find what caused that extensive bone marrow infiltration. These images are in contrast to benign osteoporotic fractures, with we do not see any prevertebral soft tissue, and we actually see quite nicely the fracture plane, quite typical for osteoporotic fracture. No bulging of the posterior elements, and it's really in contradiction with that pathological fracture of the bone infiltration. CT findings predictive of malignant vertebral fractures revolve around cortical destruction and the presence of masses, of soft tissue masses. And when it comes to MR imaging, epidural or focal paravertebral soft tissue masses are the things that we need to look for. The signal intensity in T1 weighted images, where the mass has lower signal than the muscles and the intervertebral disc. And when we have persistent edema within the presumed fracture that lasts more than 3 months. This is a very nice table. We won't get through that, just to show you that we have some characteristics that can actually help us decide whether that fracture is benign or malignant. So about metastasis, again, we say that low signal in T1 weighted images, and this is very important, is more sensitive than osteolysis in CT. Osteolytic metastases tend to be aggressive, whereas sclerotic metastasis usually demonstrate slower progression. Tumor cell proliferation within the bone marrow invariably predates bone destruction, so that's why MRI is so useful. Computer tomography is modality of choice for evaluating the ribs because of the thick cortex. And evaluating for sclerotic change when we have a known lytic metastasis is actually of great importance, because we actually know that chemo or radiotherapy actually worked. So CT does not have a role in primary assessment for the presence of metastasis. When we have a staging scan, we cannot actually rule out metastasis. And whole body MRI, you cannot have a whole body MRI. You can have MRI to actually check the spine, or have a very problem solving scan, but you cannot actually widely use it for whole body bone marrow depositions. So that's where bone scintigraphy scan comes, and they are the most sensitive routine imaging modality for the whole skeleton. And what we actually know is that they demonstrate increased uptake, the hotspot, but this is more sensitive for the osteoblastic lesions, and in very aggressive purely lytic lesions, a photopenic defect may be visible, a cold spot, and we have a false negative scan. Something that I want you to have to keep in mind are the rib fractures, because sometimes, and we've seen that, they have been reported as pathological hotspots in bone scans. What we need to look for is the multi-level distribution, and if we have the available CT scan, we can actually see that these are probably trauma-related bone rib fractures and not metastatic deposits, because of the multi-level and because of the appearance of the multi-level fractures. And last but not least, there is multiple myeloma. And when multiple lytic lesions in an adult older than 40 years old appear, there's always a suggestion of metastasis or multiple myeloma. Low-dose CT is important for proving osteolytic lesions, and MRI for proving bone marrow affection. Whole body MRI is suitable for demonstration of the tumor burden. Just to keep in mind that myelomatous lesions can be present with normal bone marrow signal intensity. And when it's diffusely distributed, it may give the false appearance of osteoporosis, and it's not difficult to be confused, believe me. Vertebral fractures from multiple myeloma can appear benign in 38% of cases. And above all, acute and subacute symptomatic myeloma-related fractures may not demonstrate any kind of edema. This is a case of a multiple myeloma spine on the left on a CT scan. Yeah, it could be very easily be confused and just say that, oh, it's an old patient with osteoporotic fractures. And on the right, there is an MRI scan with some more worrying features. Just to close that session and that lecture, to be more specific, we have to keep in mind and remember that it's not always easy to differentiate malignant from benign lesions. An MRI is superior to CT imaging for differentiation, but cannot stand alone, and a combination of tests is necessary. And that normal imaging does not exclude bone marrow infiltration. Thank you very much for attending and listening. Enjoy summer, and I'll be here for any questions.